starting with the first question. So you had a 62-year-old woman who comes to the GP for decreased vision. And worsening headaches since this morning. She has hypertension and hypercholesterolemia. Her pulse is 119 and irregular. Her current medications include ramipril and atorvastatin. Ocular and fundoscopic examination show no abnormalities. The findings of visual field testing are shown. Which of the following is most likely the cause of this patient's symptoms? So decreased vision, worsening headaches, background of hypertension and hypercholesterolemia. The pulse is 119. I don't know, would it be better to just go through the answers because you've already tried it, so you already know what you've replied to. But if you have any, concerns or questions, just ask along the way. So the answer for this one was occlusion of the posterior cerebral artery. I'd already clicked it earlier on, but usually due to emboli from it, you get posterior cerebral artery when you have emboli from the vertebral vessels, the aorta or the heart, and you get contralateral homonymous heminopia with macular sparing. And macular spared because macular tracts have additional blood supply from middle cerebral arteries. So that was the answer for this question. The next one was a 31-year-old woman with multiple sclerosis who comes to the GP because of a 4-day history of cramps in her left leg. The physical examination shows flexion of the left hip and increased tone in the thigh muscles. A local anesthetic block of which of the following nerves would most likely improve this patient's condition the most? So in this case, they're asking which nerve is supplying the hip flexors, and that's usually L2, L4. So that would be the femoral nerve. So you have motor fibers from the femoral nerve, L2, L4, that innervate the hip flexors. And if you block selectively the femoral nerve, you'd improve the hip flexor spasticity that she's experiencing. But one of the side effects would be, loss of knee extension because it also innervates the quadriceps. And the femoral nerves also provide sensory fibers. So another side effect would be loss of feeling of the anterior medial thigh because of blocking of the anterior cutaneous branches. And also the medial lower leg and foot. Okay, so that was question 2. Then you've got the third one, a 15-year-old girl who comes to the GP for the evaluation of a painless swelling under the left lower jaw for 5 months. Her 18-year-old sister has a history of acute lymphoblastic leukemia that's been in remission for 11 years. The patient's temperature is 37 degrees. Her physical examination shows a 3 by 2 centimeters swelling on the left side, 4 centimeters below the base of the mandible and the anterior of the 𝕊𝕆₂ muscle. The swelling is soft and fluctuant. It doesn't move with swallowing, and forced exhalation against the closed glottis doesn't increase the size of the swelling. Ultrasound shows a round mass with uniform low echogenicity and no internal septations. Which of the following is the most likely diagnosis? So the fact that, it doesn't move when she exhales through a closed glottis, that kind of rules out the thyroglossal duct cyst. That the location goes very much with branchial cleft cyst. So at the moment, that's our first one. The fact that it doesn't have any septations, that kind of rules out all the carotid body, the tumor, and the hygroma, because they usually have septations as well. So at the moment, this would be our number 1. They're painless, and it's an anterior triangle sort of right in front of the 𝕊𝕆₂. There's a nice picture as well that you can find online of the neck triangles, and it's the childhood swellings that you can get on the anterior triangle and the posterior triangle. I found that really useful. So if you Google that, you might be able to find it. It's really good. But it helps you, with your differentials when you're reading a question or when you're seeing a patient and they have a swelling. If you have that picture in your head, it's a lot easier. But in this case, the swelling very much goes with a branchial cleft cyst, which typically presents as a painless cystic swelling. It's in the anterior triangle of the neck between the upper 1/3 and the lower 2/3 of the anterior border of the 𝕊𝕆₂, and it's caused by failure of the second brachial cleft or cervical sinus to obliterate. So the answer for this question was E, branchial cleft cyst. Okay. After that, you had a 68-year-old woman who was brought to the emergency room because of pain in her right shoulder after falling down the stairs in her apartment. She has a history of postmenopausal osteoporosis. Her current medications are alendronate vitamin D and calcium supplementation. So alendronate is a bisphosphonate, and she's on vitamin D and calcium. Physical examination shows shortening of the right arm, as well as a tenderness and swelling over the right shoulder. The range of motion of the right arm is limited by pain, and an X-ray of the right shoulder shows a fracture of the surgical neck of the humerus. Which of the following movements is most likely to be impaired in this patient? So in the surgical neck, you've got the axillary nerve, and in the middle of the humerus, it would have been the radial nerve. So in this case, it's something to do with the axillary nerve. And then looking at the answers, so you've got wrist extension, elbow flexion, arm abduction, thumb abduction, or wrist flexion. And it's more likely going to be arm abduction because that's supplied by the femoral nerve. So impaired arm abduction over 15 degrees due to weakness of the deltoid muscles, a classical finding of axillary nerve injury. The axillary nerve originates from the posterior cord of the brachial plexus, and you have the fibers from C5 to C6 going through the quadrangular space to innervate the deltoid. And due to its proximity of the surgical neck of the humerus, the nerve can become injured by a proximal humerus fracture, like in this patient's case. And then other symptoms you can have from axillary nerve injury would be impaired external rotation of the arm because of paralysis of the teres minor muscle, and you also have sensory loss over the lateral aspect of the shoulder, over the deltoid area. Okay. So next you had a 68-year-old man who came to the GP for evaluation of right flank pain. He has a history of diabetes and peripheral artery disease. His blood pressure is 160/90, and on examination he has abdominal tenderness and right flank tenderness. When you do an ultrasound, it shows dilation of the right ureter and the renal pelvis. Which of the following is most likely the underlying cause of this patient's condition? So he's 68, he has right flank pain, background of diabetes and peripheral artery disease. His blood pressure is 166 systolic. He has abdominal tenderness and right flank tenderness. And when you do ultrasound, there's right ureter, dilation of the right ureter and right renal pelvis. So that sounds like hydronephrosis. And which of the following is the most underlying cause of this patient's condition? Because of the high blood pressure, my mind immediately went to renal artery stenosis, but then that would cause necrosis, and it would stop the blood flow to the kidney. So they'd have, a shrunken kidney rather than an enlarged kidney or hydronephrosis. It wouldn't cause some sort of obstruction. So that would rule that one out. And so next, out of the rest of the options, common iliac artery aneurysm would be the only one that makes sense because it could actually push on the ureter and cause hydronephrosis, cause an obstruction. So the answer for this one's common iliac artery aneurysm. It's very rare. The patient has right flank tenderness, abdominal pain, and hypertension. They're all symptoms of urinary tract obstruction, which can over time lead to hydronephrosis, which he had because we saw that on the ultrasound scan. The middle portion of the ureter runs in front of the common iliac artery, and so if you had an aneurysm and if it was large enough of the common external or internal iliac artery, it can press on the ureter, and that can cause urinary tract obstruction and hydronephrosis as well.